right, well, welcome to another Six Patterns video. My name is Max.
I'm Kevin.
And today I thought we'd focus on one of the things that we see pathologists struggling with most often, and that is the fibrotic biopsy that may not be the usual type of fibrosis in the form of usual interstitial pneumonia of the clinical syndrome, idiopathic pulmonary fibrosis.
Right, big problem.
Big problem, and a problem that we see pathologists stumble over. They tend to call most biopsies with abundant fibrosis UIP of IPF.
So we can help. It's just one of those things that you have to sort of get a mindset about evaluating architecture in the biopsy and figuring out where the fibrosis is predominantly located.
Exactly. It's kind of like the old real estate thing, location, location, location. So the area within the biopsy for where the fibrosis is becomes critically important, not just the presence of advanced fibrosis or not.
Right.
So what do you think of this case so far? Like, we're just looking at a few low power images.
Well, it's clear to me that there's a focality to this process, meaning there are parts of this biopsy that seem to be more fibrotic than others. So we do have the so-called patchwork quilt of usual interstitial pneumonia pattern. And now our job is to say this is advanced fibrosis. It's never a good thing.
No.
We have to presume that the patient has changes diffusely on imaging and not just a localized area like in the middle lobe or lingula that's scarred. So with diffuse fibrosis, you could argue it's a bad thing, so who cares? Why don't we just call everything just bad fibrosis?
But it does matter.
It does
because
matter.
the treatment is different, especially in today's day of the anti-fibrotic agents.
Which are expensive too. So
And
the
give you
clinician,
diarrhea if you take them.
yeah, exactly.
So you only want to take them if you really do have a potential benefit.
Right.
So here's a case, advanced fibrosis. We even have what I would say from low power here is microscopic honeycomb remodeling.
Right. Small mucus-filled cysts in fibrosis.
And I think most clinicians, if you tell them microscopic honeycomb remodeling in fibroblast foci, they're going to think you're talking about UIP of IPF.
Right.
But I think even from this power, we can see histologic features that are suggesting something other than UIP of IPF.
Right. I think it strikes me that the microscopic cystic mucus cysts here are kind of nodular in appearance, and we've got one focus right in the middle of the screen now where I can see blue airway epithelium with a little fibrosis around it and way too many structures in here for normal bronchiole. So a normal anatomy would have a bronchiole and an artery at the center of the lobule, and here we have way too many spaces lined by respiratory epithelium.
There's the cilia there.
Yeah, you can see them even from this power. So with this degree of complex remodeling, that's the term we used for this of the airways, complex remodeling, in a central lobular distribution, this has to raise a red flag about UIP of IPF. That is not a feature of UIP of IPF.
Right, because in fact the fibrosis of UIP of IPF is the opposite. It's at the periphery of the lobule.
And spares this zone.
And spares the central lobular region. So anytime we see advanced central lobular fibrosis at the center of the lobule with small airways remodeling in the form of peribronchiolar metaplasia and mucostasis, we think perhaps this advanced fibrosis is related to a chronic inhalational injury.
Correct.
And
Correct.
which two pop up in your mind first?
Well, hypersensitivity pneumonitis, chronic type.
Chronic hypersensitivity pneumonitis,
What else do you like?
chronic aspiration.
Yeah, aspiration bronchiolitis. That's different than aspiration pneumonia. So it's important to distinguish those two because aspiration bronchiolitis can have the peribronchial metaplasia, can have small granulomas with foreign material only centered on the small airways.
Exactly.
It produces a nodular picture on imaging.
Exactly. So this patient has advanced fibrosis that's in a central lobular distribution. We're starting to think chronic inhalational injury like chronic hypersensitivity, chronic aspiration bronchiolitis. And so then we have to search through the whole biopsy and we'd be looking for poorly formed granulomas of hypersensitivity pneumonitis, or perhaps some food material that would suggest.
Like pulse granules, seed material.
Exactly.
Aspirated.
In this case, here, right in the central lobular region, and in fact, this is beautiful, right? Because here's a pulmonary artery right here, so we know we're right next to an airway. In fact, this might be the edge of the airway right here. And we have this vague collection of histiocytes, a few multinucleated giant cells, a classic poorly formed interstitial granuloma in the setting of a fibrotic disease that's centrilobular.
Right.
Chronic hypersensitivity pneumonitis must be at the top of the differential diagnosis here.
But what if I find a fibroblast focus associated with that airway epithelium?
The old question of the fibroblast focus associated with airway epithelium. So the fibroblast focus has taken on sort of a life of its own. It's got its own lore in pulmonary pathology because fibroblast foci are equivalent almost in many people's minds with UIP of IPF.
Right.
But what exactly is the fibroblast focus?
Well, many people have commented on that, including myself. Since you can see them in diseases like pneumothorax.
Exactly.
In young people, spontaneous pneumothorax, you can find fibroblast foci at the edge of scar. So there's something related to scar. We know that, but they're not an absolute indicator of UIP. So be careful with the fibroblast focus. If you want to know more about this, I would suggest reading in a book about UIP of IPF and the fact that in UIP of IPF you find more fibroblast foci than you do in other conditions. That is true.
Very true.
And you can't diagnose UIP without at least one fibroblast focus.
That is true too. But if your fibroblast focus is centered around an airway, I would take a step back from calling that UIP of IPF because that suggests centrilobular chronic inhalational injury.
Yeah.
So, this is a case of advanced chronic hypersensitivity pneumonitis. I would expect the patient to have some evidence of airways disease on the imaging studies, probably what led to the biopsy, some evidence of air trapping, perhaps a little bit of GGO.
Maybe upper lobe involvement as well as lower lobe. And here we even have a piece of bone in this biopsy on the right side. What do you make of that, Max?
Well, we see bone and osseous metaplasia in basically any fibrotic context.
Right.
So to me, when I see bone, I just think, well, that's part of the histologic features of advanced fibrosis.
Excellent.
Okay, well, I think that sums it up for this case of an advanced fibrosing disease that looks most like chronic hypersensitivity pneumonitis.
And what would you suggest people do next?
Well, I would suggest first putting together a reasonable report that the clinicians can understand. So would you want to call this UIP in your diagnosis?
Well, you might call it a UIP pattern fibrosis with a caveat in your comment.
A strong caveat.
A strong caveat that most of the features suggest this patient has chronic hypersensitivity pneumonitis.
So if I was the pulmonologist, what I would do next is do a detailed investigation of the patient's environment for exposure to an organic antigen, i.e. a bird.
Right. So, comments.
All right. So
Like your comments?
Yep. Like the video and comment below. Thank you.